When health is given for free, healthcare is being a financial burden until it comes at the surface of humanity. I would like first to welcome Minister Bouassi to give his speech. Thank you.
Well, frankly speaking, I was convinced that this panel would be directed and managed by my colleague, Minister of Health, because so many doctors, so impressive. So they insisted, you have to be there. I just don't know why. In fact, I'm Minister of Social Affairs. So I asked the advice of the Minister of Health, like, what should I do? He said, it's very easy. Just wait until the end, don't say anything, and then recapitulate what they have said, and you will sound so smart, they will love it. You understood that he was a consultant previously, yeah? So the problem is I'm starting, in fact, so I cannot even recapitulate, so the mission is very hard. What I'm gonna talk about, of course, not about the medical system and medical technicalities. I'm gonna talk about the human aspect of health, as Minister of Health, and mainly as a Lebanese citizen. Health should be affordable. It should be accessible. It should be available. Easy to say, hard to implement, because health doesn't have a price, but it does have a cost. When we say it has to be accessible to everyone, I think, of course, basically, of poor people. How to target them, how to allow them to get to the healthcare system, and mainly, how to keep politics out of it. Because if we go through this with a political point of view, if I give this card that I have in the ministry for poor people that provides health, only from a political point of view, for the sake of my party, for instance, or for myself, we'll be destroying the system. So we have to create a compact system, both on the procedures, on the political level, on the financial level, and on the healthcare level. For this, I advise that we try to tackle during this meeting 3 main issues. First issue, how to target vulnerable people. Knowing that vulnerable people are not only poor people, it could be genetics that's threatening them. It could be their financial conditions. We know that nutrition has an influence, lack of work has an influence. Look at myself, not at Gibran, like, I'm eating less, getting fatter, because I'm eating bad, in fact. So we have to tackle this, nutrition, life conditions, habitat conditions, livelihood, all these aspects, to be able to prevent and to give more awareness to fragile segments of the population. We can do it. But it needs to create more than speeches, a real system. Another thing that we can do throughout our SDCs, Social Development Centers, the Ministry of Social Affairs has 228 SDCs all over the country, and they can be very useful to be in direct contact with vulnerable people. When I say vulnerable people, I do think as well about elderly people. Some things could be done to know the state, the situation, in fact, for these segments of the population, how we can help them better, how we can provide the health care better. And I'm sure if we do a preventive action, it will cost us less and will provide better health support. I will finish with another aspect that unfortunately for a long time it was a taboo, is disabled people. Kids, adults, whatever. Disability can be motor, like physical disability, it can be mental disability. We have to tackle this as well. It is an issue of public health. So we are proud to have you here, dear doctors, and we hope that together we're gonna bring some answers to these questions, and I do thank you.
I would like to thank Minister Bouassi for his speech. I would like to welcome our first 4 panelists for the first session. Dr. Usama Hamdan from the United States, Dr. Natty Hakim from the United Kingdom, Dr. Gabi Mawad from the United States, and Dr. Fernando Hakim from Colombia, and finally, last but not least, Dr. Johnny Salame from the United States and from Lebanon. And we will see how Lebanese doctors who are coming to Lebanon and giving the chance and the opportunities to many hospitals so they can practice and help a lot in the humanitarian sector too. Our first, before we start with our first panelist, I would like to...
I solemnly pledge to consecrate...
No, it's okay, the video, it's okay.
My life to the service of humanity.
I will give my teachers the respect and gratitude that is their due.
I will practice my profession with conscience and dignity.
The health of my patient will be my first consideration.
I will respect the secrets that are confided in me, even after the patient has died.
I will maintain by all the means in my power
The honor and the noble traditions of the medical profession.
بتذكر غرفة العمليات بحياتهم ما عملوا زرع أو أي عملية كبيرة.
A ingeniarse un sistema para disminuir el tamaño de los ventrículos y fue cuando hizo la primera válvula en los años 60.
نحن نودع كل طاقاتنا بتصرف وزير الصحة، وزارة الصحة ونقابة الأطباء لحتى كلنا نتساعد مع بعض.
Hi, my name is Dr. Usama Hamdan. I'm the president of Global Smile Foundation.
We will start with our first panelist, Dr. Usama Hamdan from the United States, President of Global Smile Foundation, Assistant Clinical Professor of Otolaryngology, Tufts University School of Medicine, Clinical Instructor in Otology and Laryngology, Harvard Medical School, Clinical Instructor of Otolaryngology, Boston University School of Medicine. Please, Dr. Hamdan.
Thank you so much.
Hi, my name is Dr. Usama Hamdan. I'm the president of Global Smile Foundation, and I would like to thank you wholeheartedly for allowing our team of volunteers to make a difference in the lives of so many underserved cleft patients throughout the world.
It's just such an amazing, almost instantaneous transformation from before surgery to after, and it's just really gratifying to be a part of that process that makes it happen.
The parents, they're so happy and so grateful for your help, and it's incredibly rewarding to see how you change lives.
Yo les agradezco mucho porque en realidad me hicieron un milagro para la vida de mi hijo.
Thank you so much. We're going to show another video shortly. This is a child born in Guayaquil, Ecuador, and the team cared for him last September. And can we show the second video, please, for Amir? The mother comes into the recovery room to see her child right after the surgery was done.
Get a chair, please.
Can we have the PowerPoint, please? I'm not sure it's going to be reaching. So Global Smile Foundation basically was founded by well-intentioned physicians throughout the United States to provide humanitarian cleft work or procedures for patients born with cleft lip and palate deformity. And what we try to do is not to provide only surgical care, but comprehensive and integrated multidisciplinary care. And this is my motivation speech when I talk to people throughout the world, is why do we do what we do? Our role as physicians born with this skill set is not given to us just by accident. We need to share it back with our humanity. And just holding on to this skill set to have a better life is not really fair. There is a lot of underserved patients throughout the world, and we need to do what we can to make this world a better place. And we always ask ourselves, why are we on this earth? Is the whole life and experience that we're going through just an experiment? How can we make life a better place for other people? And I always tell people, ask yourself every single day, what have you done today to make this world a better place, even for one or two individuals? Next, please. So those who donate their time on volunteering basis have been shown that they live longer, they're happier, they're more content, and they're healthier. So I certainly will encourage everyone to try to volunteer a bit and give back to humanity rather than us being involved with our own personal problems throughout the whole day and the whole year. And you clearly will be achieving a much higher level of contentment. Next. Global Smile Foundation provides the surgical intervention on a humanitarian basis throughout the world. We've been doing this for the past 30 years in Ecuador, in Latin America, Brazil, Peru, El Salvador, Guatemala, and we started actually in Lebanon in 2012. We started with 3 patients in 2012, and currently we're doing 220 cases of cleft lip and palate repair on underserved patients. Everything is for free. We're providing all the care for them on pro bono basis. Next. And as Ambassador Abu Asi said, or Excellency Abu Asi said, that the social impact is quite impressive. For every patient that is left in Lebanon and many other places with a cleft lip and palate deformity, you need 3 to 5 family members to take care of them. And this is depriving the society from 3 to 5 productive members of the society to produce. And unfortunately, the incidence in Lebanon turned to be out 3 times higher than in the developing world. The developed world, it's 1 in 422 as compared to 1 in 1500. And a lot of it actually is based on consanguinity, lack of folic acid, smoking, exposure to smoking, and a variety of other things that many of them are preventable, actually, hopefully with the support of the government. Next. So basically, each mission we see around 300 patients, and we operate on as many as 75 or 80 patients, along with integrated dental services, psychotherapy, speech therapy, family support, and the whole integrated work around cleft. Next. And we have a team comprised of well-experienced surgeons, anesthesiologists, nurses, biomedical engineers, craniofacial dentists, who provide the whole integrated care and not the hit-and-run approach. And we keep coming back to the same country year after year to provide this kind of work. This is an example of our team in Ecuador, around 45 team members from the United States. Many of them actually are also of Lebanese and Arab descent, and the number of patients that we've been taking care of. Next. And we also train a lot of people on the ground, so we're going to teach them how to fish and not to keep fishing for them. So we have educational programs and fellowships, and our first fellow who just graduated from Brazil established a program in northern Brazil, in Macapá, on the Amazonian border, and we did in 1 year more than what was done in the whole region in the last 10 years as well. Next. And this is Fernando training the other physician. Actually, our team is currently operating at Fouadi Khouri Hospital in Beirut. We've done an average of 30 cases since the beginning of the week. Next. And I'm going to quickly just run you through the pictures of some of the patients that we've taken care of over the last many years. And every patient has a story. Amir, we did the surgery on him in Ecuador in September, and we just fixed his lip his palate in Ecuador in March. Lady was operated on by one of the local surgeons 4 times, and this is her after 1 surgical intervention by Global Smile Foundation. And this is Alexander from El Salvador, and we've done the lip and palate for him. Mamadou came back to us in Ivory Coast 2 years later, and he told me, I go back to school right now, and they tell me my mouth is not broken. Everybody has a story. I have, Haura was the first patient I did at AUB 3 years ago using augmented reality to enhance educational training, and this is her a year later. Aileen, after 5 years in Ecuador. Karim, we did only 1 surgery on him in 2015, and this is him actually a year later having a normal life. And we can go through the pictures gradually, yeah. So basically, again, Marciano, we did him actually in northern Peru. His wife came back to me, and she said, right in the recovery room, she said, thank you, my husband just gave me my first kiss in 30 years of marriage. They have been married for 30 years, and we're the only group actually in the United States right now that has a 25-year follow-up of our own patients from year to year. And many of our patients, like Freddie, is now 20-year-old, and he's a volunteer with Global Smile Foundation. Evelyn is a model and goes to school. And this is Sebastian, who's also a budding young volunteer. Diego is now 23-year-old, and we're training him as well as our photographer. So it's been quite a wonderful journey, and I would certainly thank you for having me here with such a privileged group of people, and thank you for giving back to humanity as well.
Thank you, Dr. Osama Hamdan. We are really proud of what you're doing, and hopefully we will have more of your services here in Lebanon. Our second panelist is Professor Natty Hakim from the United Kingdom, Professor of Surgery at the Imperial College London, and he is the Imperial College President's Envoy. He was a part of the team which performed the first world arm transplant. Please.
Thank you very much. While we're getting the slides, I want to thank Your Excellency, Minister of Foreign Affairs, for having invited me yet again to be here today at the LDE, at an outstanding meeting, and congratulations for this success, and Karen again for being so kind to put me on the panel. I'd like to talk about, following what Dr. Osama has talked about, which is quite impressive, my experience in kidney transplantation in the third world countries, to confirm to all of you that it is really very simple to do even big surgeries in the most remote areas of the world. Next slide, please. The first thing I've done, this was in Yemen. They've never done any kidney transplants in Aden. I went in 2003 and performed 5 transplants, live-related transplants. If you could you just slow down the projector, please? Make sure it doesn't go fast. Thanks. And this is actually Aden, a beautiful city, and I'm sure you know that everything is not going very well in that part of the world. So we performed the first ever 5 kidney transplants, live-related, successfully in only a matter of 3 days altogether, and that was a big success. Those patients did very well, otherwise they would have died because there's no dialysis in Yemen. Next slide, please. So all patients were between the ages of 20 and 40. We were very impressed by the quality of the pre-operative assessment. This was done in Saudi and the patients were transported in Yemen. We had a press conference a few days, actually the next day, where all 5 donors were operated on hardly 24 hours earlier, were sitting in the front row of the press conference. It was truly a triumph, and I still cannot believe that we performed 10 surgeries in less than 24 hours. This is one of the nephrologists from Saudi who was present to look after the patients. And Dr. Shaheen is the head of kidney transplantation in Saudi. Next, please. Then we moved to another continent, Nigeria, where I started kidney transplantation in Abuja, which is the capital of Nigeria. Nigeria is the very wealthy country, as you all know, but they haven't even got made the effort to start kidney transplantations. We did the first 8 transplants there, and this is Abuja, the center of the capital. Next slide. You'll be surprised that the first kidney transplant I did is in a tiny house. Look at this house. You would think it is a cottage, but this is where I was taken on that morning when I arrived to a small house in Nigeria, in Abuja. So I performed the first kidney transplant in the bedroom, and this is the bedroom which converted to an operating room. And we washed our hands in the bathroom, and this is what happened. So to show you that you can do big surgeries even in a small cottage in the center of Africa. This is my assistant, who actually I trained in England, who is from Nigeria, and he helped me with the first ever transplant in Abuja. It was a big success, and since that time we've done 28 successful kidney transplants in Abuja. When we finished that first day, there was a press release saying 16 surgeons from Nigeria, led by Professor Hakim, have performed surgery, but this was a lie. I was there with that assistant. There was no one else, to show you that it is easy to do anything without the much equipment in any place of the world. And this is the announcement on that day. They had prepared the poster before I even transplanted, so they predicted that we would have a successful kidney transplant on that day. Next, please. This is the donor, which again, the next day of having donated, he was sitting in the conference room. This is the first recipient, who was his brother. All this was done completely gratis, so it was a benevolent effort to the people of Nigeria. And this was in 2013. This was my assistant. Now I went back, as I said, I performed 27 other transplants in a proper hospital this time, with a much larger space, but again, all you need is only one assistant to perform the surgery. They're all very happy to see that the success can happen even in Nigeria, where they thought that would never ever happen. Next slide, please. Now we move to Sudan. Sudan, 6 cases. Again, Sudan, they did some kidney transplants in the past, but it all dried up. So I went back 2 years ago following the invite of a Sudanese guy I transplanted in London. He said, you know, would like to come and help us in Sudan, and I did go. We performed again 6 transplants thanks to this gentleman his name is Mr. Hagar, who is Lebanese origin but born in Sudan, who invited me and funded the 6 transplants in Sudan. This was a big success. This is Khartoum, which is quite a lovely city. You would not think it looks like that when you hear about Khartoum, but this was a big success on that day. So we did the 6 kidney transplants in Ibn Sina Renal Hospital, and they all did very well indeed, and I was very proud to have restarted kidney transplantation in Sudan. Those were all 6 live-related couples, and they all did extremely well on that experience. This is the Ibn Sina Hospital, which is in the center, and the center with the kidney transplantation on that day. So this is the theater space. This was, you know, you can see we were quite tired after having performed 6 kidney transplants. And this is my assistant who is sleeping, you can see on the chair. So, I had to wake him up a few times. And this is one of the first donors or recipients we've performed. Quite humbling experience, I have to say, to be able to do all this transplant in a new territory, what I've never seen before. But the success is such that it makes us all proud to offer our time to, as Dr. Osama mentioned, poorer people in this world. So successful kidney transplantation improves the well-being of patients with end-stage renal failure. Developing countries with a gaping dearth of facilities for adequate dialysis, transplantation appears to offer the most and the best solution for those patients. So having said that, we would invite Your Excellency, the Minister and the Minister of Health to maybe encourage many more transplants to take place in Lebanon, because you've got fantastic facilities. And I'm sure, hopefully, you'll be convinced that if you can do it in a cottage, you can do it in any decent hospital in Lebanon. And unfortunately, this has not happened. And this should happen, because your patients are going to Syria, Egypt, Iran, London, etc., with poor results and getting hepatitis C infected. So I think this is what I would like to do. And I want to thank again Karen Bustani for inviting me here today. Thank you.
Thank you, Dr. Hakim. It was a pleasure, and it's always a pleasure. And as you said, this is our aim, is to really propose to the Lebanese hospitals for them to team up with us and for you to come and give your full experience here.
Inshallah.
Inshallah. Our third panelist is Dr. Gabi Mawad. He's an assistant professor of obstetrics and gynecology at the George Washington University School of Medicine and Health Sciences. Dr. Mawad is an expert in robotic surgery and teaches nationally the Master's Advanced Course in Robotic Surgery to other gynecologic surgeons to advance their robotic skills. Please, Doctor. Thank you.
Well, I probably had one of those aha moments very early on. I had two patients in the room. One had had an open procedure and the other had had a robotic Da Vinci system procedure. And one was laying in bed, not really very comfortable, and the other was sitting in the chair, chit-chatting with her family as if, they were out to breakfast. And that really was the first clue that this was something very different, something that was very important for surgery. And I think it's really revolutionized what we do now.
Well, like everything that has a learning curve, I was skeptical. I was very confident in my laparoscopic skills. I acknowledged the better vision with the robotic system and the wristed instrument, but I was under the impression it's taking too long and it's very costly. After uncovering the truth around the cost, I realized that the robot is simply a tool that enabled me to do the most complex cases in a minimally invasive manner.
I came from doing quite a few laparoscopic hysterectomies, laparoscopic assisted hysterectomies, and vaginal hysterectomies. I had a system down, I was highly efficient. I think it was a hard transition for me because I looked at this robotic system in the wrong light. I looked at it as merely a laparoscopic approach using robotics, and I since then have changed my opinion about that. And once I figured that out and I wrapped my head around that and quit trying to make it conform to my old laparoscopic ways, I fell in love.
There are very few patients that I will not be able to assess to determine if this is a good tool for them, and the majority of the patients are. And it's just so wonderful to be able to get them back on their feet and to offer this to them.
When we initially started doing Da Vinci surgery, we would normally see the patient back in 6 to 8 weeks, much as we had done with open surgery. And what we found is they were back to doing things much quicker.
less blood loss, they recuperate so much faster, they have less admissions to the hospital, they just do so much better.
It's incredibly gratifying to be able to offer patients an opportunity to feel better in a way that very few other people can.
I watch my patients and how well they did. I recently had to have a double hernia repair, and I found an accomplished robotic surgeon that does inguinal repair, and I was back to work on Monday.
About probably the time that Da Vinci robotic surgery came along, I was having a lot of problems with my hands. I thought I had rheumatoid arthritis. Well, it turned out it wasn't. It was just wear and tear. And I really couldn't see myself doing anything else. And so that's when I really adopted this in a big way. And now I don't have any problems whatsoever. And, you know, the sky's the limit. It's revolutionized my life.
For 3D vision, it gave me the opportunity to see anatomy in a way that I hadn't been able to see it consistently during laparoscopic procedures. The ergonomics of it allowed us to do longer procedures without muscle strain and discomfort. And it also allowed us to perform procedures much the way we would an open procedure, but with the advantage of being minimally invasive.
In our experience at GW, robotic does not cost more than laparoscopy. I think consistency, cost responsibility, and training are key for cost containment in robotic surgery.
Probably within about a year to 2 years after I began using the robot for the sacrocolpopexy operation, that the hospital noticed the benefits and decided to purchase not one but two more robots, and was able to keep up with my pace as far as the volume that I wanted to do.
For me, patients were never dollar sign or numbers and should never be regarded as such. Patient deserves the best care. As a surgeon, I strive to provide the best care for my patients. Everybody is someone's daughter's, sister, mother, friend. As a father of a newborn baby girl, I keep reminding me every day how important to provide the best for every single patient.
I'm not here to talk about today myself. I want to raise a very crucial issue, which is women's health care. Because if we need to reform the healthcare, women are the gatekeepers of the healthcare. They make healthcare decisions for their caregiver, their children, their husbands, their family, their communities. I think in Lebanon we have a greater underserved population, especially for women, because women in Lebanon are underpowered in most of the communities. And what we need to do is we empower them to make the right decisions. I think women deserve the best care, and then we need to shift in Lebanon. We have a great opportunity to shift from volume-based care to a value-based care. And what is value? Value is when we provide the best outcomes for our patient in less costs. The problem is the start to value care starts with measuring outcomes. We need to create a database system. If we say we are the best in doing everything, we might be, but we need to measure it scientifically, because if we are the best in doing things, we should teach the word. If we are not the best at doing things, we have areas of improvement, and this is the way how we're gonna improve our fragmented healthcare. Because policymakers, insurances, hospital, Ministry of Social Affairs, Ministry of Healthcare needs to acknowledge these fragmentation in the healthcare system to help improve it. And I think the entry is women's healthcare. Lebanon have a great opportunity to be a leader in the Arab community in healthcare by providing an exemplary healthcare to underprivileged women. And this will reduce cost. We need to encourage more ambulatory surgery, not penalize physicians for doing surgery in shorter days. We need to use our resources very carefully. The hospitals, it's not whenever you have a headache, go to the hospital and spend 2 days just to watch you. We need to use our resources very good, because we have been a leader in the area, but we need to excel and be a leader in the world. All our physicians are leading the world in everything they do, and it's time to invest in technology, invest in youth to reform our healthcare. Thank you.
I would like to thank you because you have thought about women, and because we are, we give life, and we are the ones who are always seeking for somebody to care for us. We are always caring for others, and we thank you for that.
You deserve the best.
And I'm sure all women here do share my opinion. Thank you. Thank you for thinking about us. Our fourth panelist is Dr. Johnny Salami. He's an associate professor and residency program director in the Department of Neurology at the AUB Medical Center. He is certified by the American Board of Psychiatry and Neurology, the American Board of Neuromuscular Medicine, and the American Board of Electrodiagnostic Medicine. Thank you, Doctor.
Thank you, Karen, for the invitation, and it's actually my honor and pleasure to be here, standing in front of you. And what I will be going over today is my journey and work on a disease called ALS. Next, please. So how did I get into ALS, and what led me to be here today? So I completed my training at Harvard Medical School, Mass General in Boston. And I was fortunate to work with the godfather of this disease, Dr. Brown, and I have his picture over there. He was the first one to find the first gene that caused the disease, and he spent all his life, 35 years, working on that disease. Next, please. So what is ALS? So it is a disease of the nervous system. It's a disease that starts either in the brain or the spinal cord, where we lose our motor nerves, and as we lose our nerves, and as the nerve dies, the muscles will die. So the patients will lose their ability to move, so all their voluntary muscles die. And as the disease progresses, they develop what we call breathing failure, so respiratory, their breathing muscle stops working, and this is the most common cause of death. Next. So the name ALS, it's actually a composite of two, where the first part is the amyotrophy. It's a Greek word for no muscle nourishment, and this is what we see when we examine this patient. We see a lot of muscle atrophy. The second part, the lateral sclerosis, this is a pathologic description. This is what we see under the microscope. And I have a cartoon there where you see the fibrosis, this loss of nerves that connect the brain to the muscle. So the name is a combination of a clinical and pathologic description. So this disease starts in one extremity and then progresses to the other. For example, it may start in the right leg and then go to the left leg and up to the arms. It typically affects people anywhere between 40 and 70. I've seen patients in their 12, 13 years of age, and I've seen patients older than 80. It's predominantly in men. People usually survive on average 3 to 5 years, but I can tell you with my experience in dealing with patients, patient can live much shorter or can live much longer, and it all has to do with the care that we can give to our patients. And this is important when we discuss later the associations and others that have been very helpful in treating this disease. Unfortunately, anyone is prone, anyone can get this disease, so it doesn't have any racial, ethnic, or socioeconomic boundaries. Unfortunately, also, we don't have a cure for it yet. We only have one medication that can slow down the disease. It's called riluzole. Next. So, next again. So after 1993, when the first gene was discovered, the first clinical trial was in 1995, and that led to the diagnosis of this disease. And from 2000 up to the present, this is where I've been involved with Dr. Brown and working at Mass General and at UMass and multiple labs between Harvard and MIT, trying to identify what other things that can cause the disease. Next. And this is a cartoon of all the genes that so far we were able to identify. So we started with one gene in 1993, and since 2010, it took us time. So this is not a typical disease that follows our traditional, what we call Mendelian, that we typically understand. So currently we know about 70% of the genes that cause familial ALS. This is a disease that runs into families of ALS. And we know about 20% of the genes that cause sporadic ALS. These are patients who don't have anyone in their family who has it. Next. So knowing these genes has helped us to create mouse models. So for each gene, we try to have a mouse that have that gene. And we use the mouse in order to try medication. And try to figure out if that medication works on the mouse, then we can move it on and try it on humans. So we created different mice that they have all these different genes. And currently we have many clinical trials that we were able to develop after we tested these medications on the mouse. What I'm more interested in, the gene therapy, and this we've been working on for the last 5 years. It's an interference RNA. So this interference RNA, it's a molecule that we all have it in our DNA. And the way it works, the interference RNA, it switch off any bad genes that we have. So what we are trying to do now, and we're testing it in mice and primates, is to take these molecules, attach it to a virus called AAV, and then inject it back into the patients. Currently, we're not doing it on patients, we're just doing it on mice. When we inject it back, it will go in and switch off these bad genes. And we're hoping this is going to be the future treatment of all these genes mutation. This is just here to show you all the currently ongoing clinical trials. We have actually 70 research trials in ALS ongoing. This is just, I want to give you like an overview of all the exciting clinical trials ongoing at the moment. Next, please. So what caused ALS? And this is, we've been, I think many in the research field have been dealing with, and we were very interested in it at Mass General and UMass, is what caused ALS. So now we know that 60% is genetically determined, but 40% is determined by the environment. So 40% of ALS is environmentally triggered. And this is where it's important, I think it's important for our country, because the environmental factors that can trigger is toxic exposure, it's the diet, and physical trauma. Next. So what's the exciting future about this disease? We have major advances in understanding the disease biology and the genetics. We have 70 trials ongoing currently trying to treat and hopefully cure this disease. When I started at MGH, we started with two research institutions trying to work on the disease. So we call it the NEALS, Northeast ALS, because it started in the Northeast in the US. Started with 2. After 2 years, we became 9 centers. Currently, we have 112 centers around the world. I've been back in Beirut about 1 year now, and we have now, Beirut is one of the NEALS center, trying to collaborate with the rest of all the centers. The other thing that I'm excited about is the benefit to other neurodegenerative disease. One of the genes we found in 2012 called C9orf72, that gene can either cause ALS or it can cause dementia, one type of the Alzheimer's dementia. And with the hope that if we can cure one disease, that can translate into other diseases like Alzheimer's, dementia, Parkinson's disease. So why I'm back, why I'm here today, and I can tell you, I think by chance, or I don't know, maybe it's meant to be, one of my first patients at Mass General, she was a Lebanese woman. She lived in Boston, but she spent 6 months in Boston, 6 months in Beirut, and I happened to get to know her and became very close friends with her and all her family. And after her, one of my neighbors turned out also to have ALS. And over about 15 years period, I've encountered many patients from Lebanon who have ALS. What struck me is it's the ALS, patients who have ALS in Lebanon, they have the disease at a much younger onset. So typically this disease hits someone in their 50s, 55. In Lebanon, the people I've seen, they were in their 30s, early 40s. And the progression of the disease was much faster. So I got more interested in. And then as I had actually many friends or brothers, sisters, or friends who developed the disease. And I started thinking, what if this would be my brother, my uncle? So I needed to do something more about it and try to understand it. Because even if we found the treatment for this disease, it's going to be something different if in Lebanon we have a different gene mutations or a different environmental trigger for this disease. So 2 months after I was starting to try to figure it out in Lebanon, I was fortunate to meet Karen, and she introduced me to Dr. Gait, who started the Lebanese Als Association. And for the last year, we've been trying to, actually it was very instrumental as an association to try to collaborate first on bringing awareness about this disease, and then try to help families, patients, and their caregivers at multiple levels, not just financial, but just be able to go to their house and talk to them and see what they need has been instrumental. I've been back and forth between Boston and Beirut, and in the last year, I personally have met 65 patients with ALS. And I can tell you out of the 65 that I've been involved in, they're all sad stories. They were diagnosed with the disease, and unfortunately there was no network to help them, no medication. Unfortunately, we don't have any medication to treat it, so it's all supportive care, which is very expensive, very tedious, not just on the patient, but on their families, on their caregivers. So we're hoping with the help of the Lebanese Association and the other physicians in the country to be able to do better work and help these patients. Thank you.
Thank you, Dr. Salemi. I want to thank you also because he's helping us. He's a volunteer in our association that was founded by Dr. Jamil Zghaib and myself. And Dr. Jamil Zghaib will be with us today. He's an ALS patient since 2008, and he wrote 9 books with his eyes only, and he is always giving conferences through Skype all over the world. He is our local Stephen Hawking, and you will meet him today at the conference, and I am very proud to be a part of this ALS association, which is the first one in the Arab world. I would like to welcome our 5th panelists before we go through our second session. Dr. Fernando Hakim from Colombia. He is the neurosurgeon at the University Hospital, Foundation Santa Fe de Bogota in Colombia. And he founded and directs Latin America's first NPH clinic and serves as a neurosurgery chairman at Hospital Universitario Foundation Santa Fe de Bogota.
Oh, yeah. Good morning to all. Thank you. I'm very, very happy to be here, and I'm going to talk to you about a disease that's called normal pressure hydrocephalus that was described by a Lebanese person, which is my father, Dr. Salomon Hakim. And this disease is probably, I would say, one of the only syndromes around the world that has a Lebanese name, which is called the Hakim syndrome. I can also say that I'm proud to be a Lebanese, and I can say I'm a Lebanese because I already have my passport as a Lebanese, thanks to Gibran, Basil, and all the government that they have helped. It's been a long work, but I finally got it. A month ago, I received the news, and I'm very happy to say I'm also a Lebanese, even though I don't speak Arabic. I wish I could. But I have all the Lebanese blood and all the Lebanese tradition inside myself. This is a very interesting disease that it's very similar to Alzheimer's, and the important thing is that at least 10% of the people that have Alzheimer's have been diagnosed with Alzheimer's. They really don't have Alzheimer's, they have NPH, and the big difference is that Alzheimer's doesn't have a cure. Normal pressure hydrocephalus, the Hakim syndrome, has a cure, and you can bring the people back to reality, treating them well, and I will show you what the disease looks like. I only have 5 minutes, so I'll try to do my best. This is just to show you, because I know everybody here is not a doctor, so I'm going to show you very fast what the disease is. This is a normal brain. As you see, this is the ventricles. And a person that has hydrocephalus will have the ventricles very big, like this. That's NPH, normal pressure hydrocephalus. Everybody has, all of us, we have our brain floating like a fish inside our cranium with CSF, cerebral spinal fluid. When you get hydrocephalus, there's hydrocephalus with a high pressure and normal pressure hydrocephalus, which was the one described by Dr. Salomon Hakim, and as a family we've been working on this disease. What does it really have? It's three things you see on a patient. It's very easy to diagnose. After you see this talk, all the people here are going to be able to diagnose the disease, even if you're not a doctor. You have magnetic gait, which is the most important thing, the way that people walk. I'll show you pictures now and movies. Dementia and incontinence. Imagine that a person has feet, the shoes with metal, and under you have magnets. It's very hard to walk. Imagine the way you walk if you have magnets under with steel shoes. It was first described in 1965 by Dr. Solomon Hakim. And the interesting thing about this, it's very nice when you read it, this is 1964. Rescuing from the oblivion at least some of those patients who, in as much as this syndrome has not been recognized previously and have been diagnosed as hopeless cases of post-traumatic encephalopathy, especially Alzheimer's, is what I want to make a very important thing here, very important point. What's normal pressure hydrocephalus? Everybody here has got a balloon and start blowing it. At the beginning, when you start blowing the balloon, it is very hard and the pressure goes high. You will notice. And once the balloon is big, just by blowing it a little bit, it keeps on being big. That's the physics of normal pressure hydrocephalus. This is very interesting. Two persons. This is a normal person that has normal pressure in his brain, and this other one has normal pressure in his brain, but his ventricles are big. That is normal pressure hydrocephalus. This is how it was diagnosed many years ago. This was Dr. Solomon Hakim, my father, who passed away 6 years ago yesterday. So it was very important for me being in Lebanon, remembering my father 6 years after he passed away. It's things of life, and it's in my heart. It's worldwide. The epidemiology hasn't been known very well, but we can know that at least 5.9% of the people over 80 years old have normal pressure hydrocephalus. The important thing here is I want to bring to all of you is that this disease exists and it hasn't been diagnosed correctly. I have had the opportunity to diagnose it in persons that, like my professor of internal medicine, had this disease 5 years. He was in a wheelchair, and in the hospital where he worked, it wasn't diagnosed. He came to my office and we diagnosed it, and he's perfect, doing a perfect life nowadays. The king of Thailand, as you know, had normal pressure hydrocephalus. I mean, I can tell you many, many people around the world that have the disease, and many people think it's Alzheimer's, and what they really have is normal pressure hydrocephalus.
¿Usted se puede levantar?
I want to show you
Bueno,
this.
venga, le vamos a ayudar a ver.
I'm sorry it's in Spanish, but it doesn't matter. Look the way he walks. See how he walks? See the way he walks? He couldn't talk.
De la vuelta.
And he was incontinence.
De la vuelta, devuélvase.
If you see anybody walking like that in the streets, he has normal pressure hydrocephalus, and many people think they have Alzheimer's. He was taken to surgery. We placed a shunt that's also called the Hakim shunt. We also have, our family has invented a shunt to treat these patients. This was just after surgery. You can see the patient walking better. He's not incontinent anymore. He's a person that's again in life. This is the Hakim shunt, as I just showed you. You place it in the patient. You treat this disease with a Hakim shunt, but you treat all hydrocephalus in the world with this device. It's a device. You put it in the ventricle, and it shunts the cerebrospinal fluid to the heart or to the abdomen. And you can program it with this device. It's a computer. You can change the pressure with magnetic impulse, and you change the pressure, It increases or decreases the pressure according to the size of the brain's ventricles or to the pressure of the brain. We did the biggest meeting last year on this disease and cerebrospinal fluid in Colombia, and this year is going to be in Japan and next year in Italy. And as a group, what are we doing? We're working, we put the patient in the hospital for 24 hours, we do all the tests, and at the end we can tell them if he has normal pressure hydrocephalus and if we can help him and bring him back to reality. This is very interesting.
I'm Bob Fowler, but this was me a couple of years ago.
This is the same person with hydrocephalus.
As you can see,
and this is him.
I wasn't well, could hardly walk, could barely make it to the bathroom in time, kept forgetting things. There was talk of Alzheimer's or Parkinson's, but what I really had was a neurological condition known as NPH. Normal pressure hydrocephalus. Then I found out that NPH can be treated.
About 1 out of every 200 people over the age of 55 has NPH. Many don't even know it. If you think you or someone you care about has NPH, call 1-888-LIFE-NPH. The sooner you speak to a specially trained registered nurse, the better.
That was me then. I was treated, and this is me now.
Don't lose your life to NPH. Take the first step and call 1-888-LIFE-NPH now.
This is my last picture, and I will read it. I wrote it last night. We have changed the life of many patients and their families by describing a disease that had no treatment and inventing the way to treat it, with the invention of a device that has been improved accordingly to the evolution of medicine. We, as a Lebanese family, are proud to share this achievement with you today.
Thank you so much. Now that we have discovered all these great doctors and their wonderful achievements, we want to see how we can implement their experience here in Lebanon in our second session. I would love to thank all the 5 doctors. Thank you so much. And please take your seats. And I would like to ask, if possible, Dr. Walid Ahmar from Australia and Dr. Ray Hashem from the United States, Dr. Marta Cadi from Brazil, Professor Raymond Sayer, and Dr. Firas Abyad, please. Thank you. Please, I would like the doctors to stay here for Q&A, for the questions, that there will be some questions at the end, please. His Excellency, Mr. Abu Asi would like... We will proceed with session 2, please. And I would like... I'm so sorry, but we are running out of time because we had a delay. I'm so sorry. I will ask you to be a bit fast because at maximum in half an hour we should give our room for the next panel. So I would like to welcome Dr. Walid Ahmar and Dr. Ray Hashem, Dr. Mata Kadi, Professor Sayer left, and Dr. Firas Abyad. Please, I need some quiet. Okay, I will proceed. Dr. Walid Ahmar is a cardiologist, president of the Australian Lebanese Medical Association and the International Lebanese Medical Association. And I want to say that this association was born 2 years ago at the LDE. Okay. So please, Dr. Walid Ahmar would like you to proceed with your presentation. Thank you.
Good morning. First, I want to thank everyone for coming.
I'm sorry, but they just told me that please we cannot have more than 4 minutes each panelists. I'm so sorry. I'm really sorry for that, because the other panel is waiting just outside.
Okay.
We were delayed because we were waiting also for all the people to be here. Thank you.
Firstly, I just want to say it's a privilege to be here once again and see my friends like Natty, Hokkien, here again at this meeting. Health is important and it matters. It transgresses religious, political and cultural divide. Without a doubt, there's universal agreement that the maintenance of an individual's health, the manner in which the health care is delivered, the understanding of one's illness and the maintenance of good health is integral to all our well-being. Now, with this motivational framework, as a cardiologist, I'm in a privileged position whereby I can work to the betterment of not only my Australian Lebanese community, but the Lebanese diaspora, and in particular the Lebanese within Lebanon, to give something back to them. And I and we owe it to them. In 2012, I established the Australian Lebanese Medical Association. We're a non-political, non-denominational association which has widespread support of our Australian Lebanese community, all the religious and political groups. We've established excellent connections with the Office of the Prime Minister of Australia and the Premiers of the States of Australia. I myself serve as a health advisor now to all the political parties within Australia. As National President of ALMA in 2014, I fostered the first ever international hospital arrangement between Monash Health in Australia and St. George University Hospital here in Lebanon. And what this has allowed is now for doctors to come be trained at Monash and students and to return back to Lebanon, not to stay in Australia, to come back and give back and to train the future doctors here. I've also facilitated a memorandum of understanding between the Lebanese Society of Cardiology and Monash Heart, and we too are getting fellows and younger doctors to come to Monash to be trained in multiple facets. I, as an interventional trainee, I train many young doctors, and we do a lot of procedures, and we're giving back to our community. Now, public health and maintenance of good health are important, and I've worked with the Heart Foundation Australia and the Anti-Cancer Council of Australia, and I've successfully changed the Tobacco Act of Australia after 3 years of negotiating campaigning to have argiri treated in the same manner as cigarette smoking. We are the first medical association in Australia to have changed an Act of Parliament. This has never been done before, but we have done this. We also have an ALMA Foundation where we provide scholarships for our students to come and study in Lebanon, to bring students from Lebanon to Australia to further foster their linkages. For guidance of our students is important. Now, I want to talk on one of my major personal goals and crusades has been to establish an International Lebanese Medical Association, or ILMA. In 2013, I set about contacting national health associations of Lebanese heritage throughout the world. And I'm proud to say we launched ILMA in 2015 in the presence of His Excellency Mrs. Jibron Basila Beta Tabib. ILMA is non-political. We are non-denominational association of medical societies throughout the world of Lebanese heritage who share common interests in health, education and research within and outside of Lebanon. ILMA comprises of over almost 15 countries now, and just most recently I've helped establish the Argentinian Lebanese Medical Association. It's taken 1.5 to 2 years to do this, but this has come to fulfillment, and it's a dream come true when you have these associations being established from nowhere. I want to stress that all ILMA associations are equal. For I ask you, how can one brother or sister be more valuable than the other? We are all equal members. ILMA is the first and only international association of Lebanese health professionals. ILMA will have a significant impact both internationally and here for health professionals in Lebanon. So how can ILMA partner the Lebanese medical professionals and health system now and into the future? In order to answer this, I want to highlight some of the goals of ILMA. Firstly, we want to provide a forum for professional, educational, research and social exchange, and to foster projects amongst our member associations throughout the world. On this theme, I'm proud to announce today that in July the 13th, in collaboration with the Lebanese Order of Physicians, unfortunately Professor Rimon had to leave, but we're having this and ILMA together to have our first joint meeting at Beta Tabib. And I want to congratulate Professor Rimon for helping me and ILMA in establishing this. This will showcase and bring many health professionals from throughout the world, as well as health professionals here in Lebanon, to collaborate together. Secondly, fostering linkages between medical and health professions in Lebanon and worldwide, and promoting exchange and education of medical practitioners and members of health professions is also important. And what this includes is further inter-hospital relationships, like we've done in Australia, and subspecialty groups. I'm in the process of establishing an international Lebanese cardiology group. We've got a number from the US, Europe, Australia, and obviously we've got the UK. We've just met someone Natty's introduced me to. As a group, we want to collaborate here with Antoine Sarkis, the new incoming Lebanese Society of Cardiology president. We have so many talented and esteemed health professionals of Lebanese heritage. Look, you've got Natty Hakim, you've got Mahir, you've got Fernando, and many others here today. These are people that we can harness and utilize their talents. And it's important, to further the knowledge of health professionals here in Lebanon, resulting in the improvement and deliverance of excellence of healthcare. And this way it cements Lebanon as a country of medical excellence in the Middle East. As in Australia, establishment of inter-hospital relationships, providing student opportunities between our countries and Lebanon is important, and it promotes future ties in the health sector. Proudly, other countries such as Belgium, France, and the USA, in addition to Australia, have all made major contributions and continue to do so on this front. Thirdly, providing guidance and advice to medical and health institutions, organizations, or government bodies is important to ILMA. And similarly, we're doing this with Monash Health and St. George University Hospital. We are guiding them with protocols and further advice. I want to stress that ILMA wants to partner the Lebanese health professionals in any facets of the health system that is relevant to them. We're not here to come and dictate to the Lebanese doctors or the health professionals. In fact, we're also here to learn from them. And by working together, we can advance healthcare. Before I finish, I do want to advise and ask you if there are any countries that are not part of ILMA or we wish to form National Lebanese Medical Association, please come and approach me after today's talk, because we're more than happy to show you our constitutions from other countries. We have constitutions in English, in Spanish, so you can, and in French, so you can utilize these constitutions and see what's appropriate to your country. Finally, in concluding, we create our own legacy, we write our own history, and hence I invite you to join me in this exciting period for the health sector in Lebanon, and for us of Lebanese heritage around the world in the health sector in writing our own history together. I ask you to join me and ILMA in helping to promote the advancement and deliverance of excellent health to the Lebanese people around the world, particularly here in Lebanon. Thank you.
Dr. Walid Ahmad, thank you so much. Our second panelist is Professor Ray Hashem, President of the American Lebanese Medical Association. Thank you.
I have the slide, please. I will really thank you a lot. Good morning, and I hope everybody stay with us here for a few minutes. So I will be quick and less than 4 minutes because we are late. So I will congratulate our effort, and then I will speak in the name of American Lebanese Medical Association in the United States. And then what I'm coming to just tell you exactly what we have accomplished, what we have delivered. So, second slide, please. What's important for us, my fellow Lebanese, like John F. Kennedy is talking, ask not what your country can do for you, but ask what you can do for your country. This is very crucial. What can we do for you? I've been in the last 10 years back and forth with all the university medical school in Lebanon, meeting with the president and the dean and everybody with the students, and ask them, what can we do for you? And this is what we can do for you. You could see our missions is concentrated in three main points I will highlight.
education, 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 scholarship to help those in need, and humanitarian work. And if you could go move again for the other slide, and you see what we have delivered. As far as conferences, we have done more than 14 international medical symposia were held in Lebanon under the auspices of ALMA, the American Lebanese Medical Association, to encourage education and teamwork among healthcare professions. Scholarships, we have awarded almost 40 scholarships to talented medical students from various medical schools in Lebanon. And all those students were selected by the dean and the financial office based on merit and financial needs. Medical education and training. This is really, we have delivered. Assisted more than 500 medical students and doctors from throughout Lebanon and medical school here. And then we helped them to achieve their higher educations and get training, residency, and fellowship programs. Medical missions. We have done many medical missions all over Lebanon. Almost more than 5,000 really patients we have seen. And you saw the team before about here. They were with us last July. More than 24 of them. We saw almost 2,000 patients in 5 days. So this is something we are really in ground. We have also mobile clinic. We move all around in Lebanon. We also actually send some donation medical equipment, more than 50 hospital bed to Hannes and also medical center. We also bring more than 200 wheelchairs to various hospitals in Lebanon. So in conclusion, I would like to really thank our Minister Gibran Basil for delivering one of the most important points, to give citizenship and to facilitate those two Lebanese are in need to have those citizenship. And the secret of our success, I will repeat, is dedication, working together as a team, and that's the only way we can deliver. And action speak louder than word. God bless you all, and God bless Lebanon. Thank you.
Thank you so much. Our third panelist is Dr. Martha Kade from Brazil. She's the president of the Syrio-Lebanese Hospital in Sao Paulo, Brazil. She will speak in Portuguese, so please, if you don't understand Portuguese, we need the translation casks.
Grande hospital, que imagem vem à cabeça?
Eu sou a única que não é médica nesse painel. Eu represento uma sociedade de senhoras que voluntariamente criaram um hospital com 35 leitos e hoje tem quase 600 leitos no Brasil. The video, please.
Quando você pensa em um grande hospital, que imagem vem à cabeça? No Sírio-Libanês, acreditamos que cada indivíduo é muito mais do que um paciente. Por isso, cuidamos de cada pessoa de forma única. A fundação da Sociedade Beneficente de Senhoras, Hospital Sírio-Libanês, foi em 1921. Quando o hospital finalmente seria inaugurado, o prédio foi desapropriado pelo governo e se tornou uma escola de cadetes. Eram os tempos da Segunda Guerra Mundial. Só em 1965 o hospital pôde funcionar. Dona Violeta Jafé resumiu nessa entrevista em 2008 os sentimentos das voluntárias.
Eu tenho 3 palavras em mente que resolveriam tudo: esquecer, perdoar e amar.
Com o apoio de muita gente, a instituição conseguiu realizar o antigo desejo, o de retribuir a São Paulo e ao Brasil a acolhida oferecida aos imigrantes que escolheram essa terra para viver.
Fortaleceu-se a ideia de criar um hospital que atendesse todas as classes sociais, sem distinção de cor, de raça ou religião. É muito gratificante poder representar, mesmo que de passagem, as nossas fundadoras, porque as pessoas passam, deixam suas contribuições, mas a instituição fica sólida, perene, sustentável, e é essa a missão da instituição.
Nosso posicionamento é conhecer para cuidar. Conhecer tecnicamente as profissões da área da saúde, mas também e principalmente conhecer o paciente em todas as suas particularidades.
No Sírio-Libanês, trabalhamos todos os dias para cuidar de todos de forma única.
Eu diria que a Sociedade Beneficente de Senhoras seria o coração e a alma, e o Hospital Sírio-Libanês, a ciência e o conhecimento com o atendimento humanizado. os dois caminham juntos, de mãos dadas.
Hospital Sírio-Libanês. Há 95 anos, conhecendo mais para cuidar cada vez melhor.
For those who need a cask, you have to give your ID outside and get it for the translation.
O nosso hospital, em nome da Sociedade Beneficente de Senhoras do Hospital Sírio-Libanês, eu me sinto honrado em representar essa instituição que é uma referência na saúde no Brasil, no setor público e no setor privado. Nossa sociedade completa 95 anos, as mulheres que criaram essa sociedade, e ela é um espírito de retribuição à comunidade sírio-libanesa, com os valores e os princípios sempre das nossas fundadoras, que uma delas foi Dona Adma Jafé. Nós somos representados pelo calor humano, a excelência, o pioneirismo, o conhecimento e a responsabilidade social. Estamos em duas cidades do Brasil, em Brasília, que é a capital federal, que temos 3 unidades, e em São Paulo começamos com 35 leitos, numa cidade de 12 milhões de habitantes, e hoje nós temos um hospital que só cuida de problemas de... Temos 469 leitos, 520 mil atendimentos no nosso centro diagnóstico mensalmente. Sorry. Next, please. E ao longo dos anos obtivemos diversas certificações, o que demonstra o nosso profissionalismo e a busca constante pelo cuidado e excelência dos nossos atendimentos. Um dos nossos pilares é o nosso Instituto de Ensino e Pesquisa, onde promovemos 348 estudos de graduação lato sensu, residências multidisciplinares, mestrado e doutorado. Next, please. Nós fazemos um trabalho pelo Brasil inteiro, capacitando mais de quase 37 mil profissionais na área da saúde, espalhados por 300 regiões, todas na saúde pública. Na pesquisa também temos um laboratório de infraestrutura, onde desenvolvemos 13 linhas de pesquisas, todas voltadas também esses trabalhos, não só para a saúde privada, mas também para a saúde pública em todo o Brasil. Temos uma preocupação muito grande com a sustentabilidade. Através de programas internos, fazemos a redução de usos naturais, através de tecnologias novas, e conseguimos diversas certificações e prêmios na área ambiental. Temos também o nosso Instituto de Responsabilidade Social, com 434 leitos, todos eles na área pública, e também fazemos quase 16 mil atendimentos no pronto atendimento. Essa história é uma história de mulheres construída em 1921, que foram pioneiras e empreendedoras, começaram com 35 leitos e hoje nós somos o maior hospital da América Latina. Foi um privilégio estar aqui com todos vocês. Muito obrigada.
Thank you so much. Our last panelist is Dr. Firas Abiad, the chairman of Rafiq Hariri University Governmental Hospital. Thank you.
Thank you. And I'd like first to thank the organizing committee for the invitation to this excellent meeting. Now, I will here be giving you the local response to the presentations that we have heard, and especially from the public sector, which I think holds a very special place in Lebanon. Why is that? Because the public sector in Lebanon is where mainly the vulnerable and needy people are treated. It targets debilitating illnesses and emergencies, and it plays a very important role in establishing the social safety net, especially in supporting other systems. The public sector is both for the vulnerable patients and a lot of the private hospitals where without the public sector, the financial burden on them would be so high that they would not be able to continue. The final aspect, which is extremely important about the public health sector, is that it gives the state legitimacy. And this is extremely important in our region and with what's happening around us, where a lot of the non-state actors are trying to establish their own legitimacy as well by establishing and giving social services. So that's why the public sector and support of the public sector is extremely important in the establishing and continuing the stability of the system in our country. So what are our biggest obstacles? Where is the area that we need you to help us with? Is it in funding and giving us money? Is it in giving us equipment? Is it in giving us know-how and doctors who have advanced knowledge? In my honest opinion, as a general manager of public hospital, neither one of these is what we really need. All of these things we have. We do have doctors who are graduates from top universities in the world, from Harvard and what have you. The equipments are things that we get. What we really have a problem in, especially in the public sector, are two things, in my opinion. The first one is the presence of systems and processes by which you cannot provide complex healthcare without the presence of the system. You can be one of the best surgeons in the world, transplant or what, and if you don't have a system that can support you, it will be very difficult for you to work and provide. The other one that we have a problem with is human capital. And in my opinion, human capital is not only the presence of people, but it's the presence of the culture, the right culture that will allow people to work and provide. If we look at all of you, you have achieved where you are now because of your culture of work ethics, hard workers, achievers. And this is something that we need to infect our public sector here. In fact, with accountability and target setting and provision. And this is something that, unfortunately, I think this is what we lack. Now, how can you help us to provide this? How can you help us to get this culture into our public sector? I think that the most important thing that we need is if we consider these attributes that we talked about, some form of a virus, something that you have that we want you to infect us with. How do you get infected with viruses? You get that through contact. You get that through continuous interaction. And I think that what we heard today about all of these missions and all of these collaborations where we have the chance to either receive you where you are with us, and thus we get this interaction and to learn from you your behavior, or whether it is about sending our people abroad to your great institutions where they get to be embedded and learn and then come back and embed these practices in our institutions. I think this is the way forward for us. We've had at the Rafiq Hariri University Hospital, we've had some experience with that. We've had in 2010-11, we've had an experience with Lebanese surgeons in Italy, where they established or started a transplant program at the hospital. And that was a 2-year program where nurses, doctors, anesthesiologists, gastroenterologists went from Lebanon to Italy and the other way around. And then that started a very good transplantation program that performed more than 40 transplantations between kidney and others. We've also currently now have a very good program with the International Committee of the Red Cross, where we have the International Committee of the Red Cross embedded in the hospital, and we have a collaboration rather than a silo approach where we have this integration, and this is also, we're seeing the effects of that on our people and in knowledge sharing and capacity building. So I want to thank you all for being and listening to my presentation. I think I'm looking forward to seeing some of the programs that we can establish together between us and the Lebanese diaspora. I think that your efforts are extremely important, and thank you.
Thank you so much. And I'm sorry, no time for questions and answers, Q&A. I'm so sorry.
Appreciate it.
Thank you so much for your presence. Thank you, doctors. Thank you, panelists. Thank you so much for your presence, really. If you have questions, you can ask the doctors or the panelists outside. Thank you.